Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of the Thyroid Answers Podcast. And today we've got another guest. Her name is Deborah Maragopoulos. She is an integrative family nurse practitioner, and she is someone who specializes in looking at and addressing problems at the hypothalamus. And for some of you may be going, I don't even know what the hypothalamus is, not sure how to spell it, but we're going to get into that. It has a big role on our overall physiology, thyroid signaling, sex hormone signaling, a whole bunch of stuff. It's like an integrative center in the brain. So without any further ado, Deborah, welcome to the Thyroid Answers Podcast. How are you today?
Fine. Thank you for having me.
Sure. So I think this is the first lengthy discussion we'll have on the hypothalamus, although we talk about it quite a bit on the podcast. But let's first start with explain to the listeners who you are as a nurse practitioner. How did you get into this space? I'm not sure how much training you had on the hypothalamus as you were going through your nurse practitioner training, but give us a little bit of background on you and why people might want to listen to what you have to say.
So I got into the hypothalamus because I started an integrative practice back in 97, where I started seeing a lot of patients that had neurological, immunological, and endocrine issues. And I felt like I really wasn't focusing on the core of their issue, even though I was integrative and trying to switch them over from maybe pharmaceuticals to more botanicals or homeopathic kind of therapies, doing more lifestyle intervention. I still was sending them out with bagfuls of supplements and lists full of things to do, and felt I really wasn't focusing on their issue. So when I started seeing patients that were really, multi-issue, the ones that have the roving hands where they're pointing to everything. Their adrenals were low, their thyroid were low, they were fatigued, they were insomniac, they were depressed, they were anxious, overweight, they had metabolic syndrome. They had multiple issues. I really was searching. And at the time in the late 90s, there wasn't good Google search. I happened to get a magazine in my office from Scientific America, and they were studying fat white mice. And they sacrificed these mice and found that their a hormone in their hypothalamus called POMC, pro-opiomelanocortin,
Mm-hmm.
was actually faulty. And so I started doing some research there. Not that I wasn't introduced to the hypothalamus, just like you were in our traditional training, but we never focused on actually diagnosing hypothalamic issues or treating it, because you can't really measure the hormones from the hypothalamus. So I started focusing on the hypothalamus and looking at what I could do for that lifestyle wise, looking for any kind of supplementation that would help. And since 2000, I have a supplement that's worked really well. I've been focusing on the hypothalamus in the core of my patients' issues, and it's worked well for all of them, including patients with thyroid disorders.
Okay, so let's get started. Let's get a little bit of background. Can you, for the listeners, tell them what the hypothalamus is, where it's located, and what its overall functions are?
So the hypothalamus is a small gland in your brain. If you actually put your fingers between your eyebrows right here and went to the center of your brain, it would be right above the brainstem. It's about the size of an almond in a shell. And it is the orchestrator of your neurological system, your immune system, and your entire endocrine system. It's the hypothalamus that produces the master hormones that tell the pituitary gland what to do. You can think of the pituitary more as your middle manager. The hypothalamus is the CEO of the company. Another way to think about it is if your body's like the hard drive and all your endocrine system is the software programs, your hypothalamus is your operating systems. So it basically maintains homeostasis in your body, meaning keeping everything in balance, not just your hormones, your neurotransmitters, and your cytokines, but your body temperature, your cellular metabolism, the rate of aging. It is not protected by the blood-brain barrier, so it's exposed to every toxin you're exposed to, every infectious agent, and all the nutrients you give it. And it is the primary coordinator for cognition and memory updating. It is actually central to mood disorders, including depression, anxiety, and bipolar. It's also central to issues with learning, ADHD, autism. There's been quite a bit of hypothalamic research related to obesity. And a lot of patients that I see that have thyroid disorders that feel like they're hypothyroid, but their blood work looks good, have central hypothyroidism. The hypothalamus is not receiving the information. There's some resistance to thyroid hormone.
Okay. So if the hypothalamus is having regulation issues, right? what might be driving challenges with hypothalamic physiology?
Well, a couple of things. The main issue with the hypothalamus in terms of its being dysfunctional, not doing its job properly, is microinflammation. So at the cellular level within the hypothalamus, there's inflammation. The endoplasmic reticulum will become stressed, and then the proteins that it's normally, so it's a cellular organelle that's normally supposed to be folding properly, does not fold those proteins properly. And that amount of stress actually causes the hypothalamus to not be able to produce the hormones that it needs to produce to orchestrate all of its homeostatic functioning. So oftentimes when we see, for instance, like insulin resistance in a patient, we assume it's peripheral, but it is always going to start at the hypothalamic level. Glucose, and the hypothalamus maintains your glucose metabolism. And so most of the resistances that we see where your body's not responding properly, it's actually up in the central controller. That's what we see with obesity and leptin resistance. It's at the central controller, the hypothalamus.
Well, it's part of the impact, right? But how would, for the listeners' sake, how is the hypothalamus impacting glucose regulation from the brain?
So the hypothalamus produces pro-opiomelanocortin as one of its main hormones, and that hormone actually controls glucose metabolism by actually orchestrating the liver's ability to store glycogen and also lipid production. It actually communicates directly to the pancreas in terms of production of insulin and glucagon. And then it actually controls cellular metabolism, and that controls it through a thyroid releasing hormone to control T3 uptake by the cells, but also controls insulin resistance as well. It's very sensitive to glucose and insulin. And so when you start to see some overloads in insulin and glucose, the first step of resistance starts at the hypothalamus before it becomes peripheral.
All right. So I would look at the glucose resistance, maybe, I think we're going to be talking about the same thing. But when we're talking about from where glucose resistance starts, right? And where the inflammation's coming from. Let's start with, you said low-grade inflammation. What's creating the low-grade inflammatory response at the hypothalamus? Is it only starting at the hypothalamus, or is it peripheral signaling because the hypothalamus is taking input from all the peripheral systems and then having to integrate them? So where's the inflammation coming from?
Any inflammation in the peripheral body actually will signal the hypothalamus. It's very sensitive to high levels of cytokines. And so that will signal the hypothalamus to actually change its functioning in order to deal with the inflammation, maybe before even signaling the thyroid or adrenal glands appropriately. It has a lot of jobs. It wears a lot of hats. So if there's major inflammation in the body, it's going to actually cut down on some of the metabolic processes. It doesn't make sense to increase metabolism if there's more inflammation. So it's constantly reading those signals. It reads through the blood, electrolytes, nutrients, but it also reads through the autonomic nervous system. It's the controller of the autonomic nervous system. So it's also picking up signals from the sympathetic and parasympathetic nervous system as well as actually signaling those nervous systems. So it's getting information from the gut. It's getting information from muscles, from bones. It's basically picking up inflammation throughout the entire body and then making decisions accordingly to try to basically keep you surviving. So your heart's functioning. And so it really is the master coordinator and very sensitive to what's happening in your internal environment as well as your external environment.
So in inflammatory, on this podcast, we often talk about the cell danger response. So cells perceive danger cues, danger signals, inflammatory signals are some of those mechanisms. So inflammatory mechanisms are going to impact the peripheral cells and signaling. That's going to feed up to the hypothalamus, but the same inflammatory mechanisms are also going to get there directly via the bloodstream to the tissue as well and have an impact directly. So we're going to get an indirect impact from the peripheral tissues, maybe a direct impact via the bloodstream, and then that's going to change homeostatic regulation to more allostatic regulation. There's threat, there's danger, and have to shift the physiology, right?
Absolutely.
So is it fair to say, I think in your literature, you talk about an unbalanced hypothalamus, but is it unbalanced, or is it a functional hypothalamus just dealing with the input? Hey, I got inflammatory mechanisms, and I've got to make these changes. From a cellular perspective, I look, from we talk about cells operating, either they're in homeostatic regulation or they're in threat state, right? If I'm threatened, I'm slowing down normal metabolism to upregulate defense mechanisms, right? So people say that, hey, you've got mitochondrial dysfunction, or you got glucose resistance, like that's broken physiology. I kind of look at it the other way, that it's the adaptive response to the inflammatory threat response. So how do you look at it from the hypothalamic standpoint? Is it dysfunction, or is it adaptive response? Or is it potentially both of those, depending on how long it's been going on?
It really has to do with the chronicity of the issue. So in acute response, the hypothalamus is being adaptive. And so maybe it's not signaling your gonads to produce sex steroids, because that's really not the most important thing here when we have to drive the stress response.
Mm-hmm.
Maybe steratogenesis is favoring adrenal hormone response rather than sex steroid response, because the hypothalamus is perceiving the stress, perceiving the danger to the system. So yes, that is totally adaptive. But if that situation continues beyond just running away from a tiger and either getting treated or eaten, then it becomes a chronic situation, which then starts to stress the hypothalamus at the cellular level. And for the hypothalamus, those are neurons. So it's made up of neuronal bodies that are very incredibly sensitive to inflammatory conditions. So for instance, we know that aging actually begins in the hypothalamus. It's hypothalamic inflammation that starts the aging process and slows down peripheral cellular metabolism. We know that issues with memory, learning, dementia, the major neurodegenerative diseases like ALS and Alzheimer's, Huntington's disease, it all begins in the hypothalamus, and there's actually atrophy of the hypothalamus in those diseases. So that it's chronicity, those things have been going on for a while before it's diagnosed. So the hypothalamus is trying to adapt, and then it can't anymore. And now everything's kind of falling apart. And so it's really about the hypothalamus being, I believe, the focus of medicine, of healthcare. It's really, if we're focusing on the hypothalamus, we're practicing upstream medicine rather than downstream medicine, focusing on, one hormone being off or one cytokine being elevated. So, and there's just a lot more research. There wasn't, when you and I were going to school, there wasn't the research in the hypothalamus. It's been a lot more recent, especially since COVID, because most of long COVID symptoms are hypothalamic dysfunction.
Yeah. So for the listener, we're talking about inflammation and this kind of the adaptive change. And, cells are like people, right? We want to make stuff and do stuff and feel good and function good, and we want to keep the system running. But when there is danger cues, we're not stopping to eat, we're not stopping to have sex, we're not stopping to take a nap. We're going to kind of slow down those pieces and put less attention and energy towards those pieces and put them towards defense. Inflammation is a good thing in the short run. It helps signal all these defense mechanisms. The problem is, as she said, as it becomes more and more chronic, now we go from homeostasis to this allostatic, this adaptive response, which does result in changes in signs and symptoms, which we think is the problem, which really the adaptive response. But then, as Deborah was saying, we get this too much, it becomes excessive. And that's the term we use in the business is called allostatic overload. And now systems have been so little attention for so long a period of time. Now we start to see dysfunction start to occur. And now that becomes the next piece of the wave of problems that start to occur. Now you're getting a lot of faulty signaling to the rest of the cellular system. And that kind of speeds that cascade of more disease in the body. Would you agree with that?
Absolutely. One way that I explain to my patients to kind of simplify it, if you think of the hypothalamus as like the teacher in a classroom, and the teacher's having to focus on the one student who's acting out, let's say that's the adrenal glands, or let's say that's the testes, or let's say that's, insulin resistance, then oftentimes the energy for the rest of the class is not there. So that the rest of the systems start to falter. So it's not going to be just one thing that's off. It's going to be multiple aspects that the hypothalamus is responsible for. But oftentimes when a person goes in and they're having symptoms, the diagnostician is looking at the one thing at the peripheral level that is off, when in reality, the hypothalamus is probably being dysregulated just by having to pay so attention to that off mechanism. Like, for instance, pro-opiomelanocortin splits into melanocyte stimulating hormone, which controls day-night cycles and metabolism, splits into cortico-releasing hormone, which actually stimulates the HPA axis, splits into thyroid-releasing hormone, which stimulates the HBT axis, also controls glucose metabolism, and then the rest is endorphins. So there's a lot that just one hormone controls, and that's one of many hormones that the hypothalamus makes. So if one thing's off, it's going to like unbalance that whole stool.
Yeah. So in the short run, it's the adaptive response, right? And so let's talk about, again, because it's on my mind since you said it. So how does someone determine, in your experience, how are you determining at what point we need to give some anti-inflammatory support to calm this cascade down versus some of this inflammatory process we need to let it go? Because people, inflammation, they're just like, well, I'll just take Advil and Tylenol and I'll take these every day, and then I won't have to worry about inflammation. I'm suppressing inflammation. We do that with corticosteroids and other things, like let's suppress. At what point do you find it's time to intervene and provide those? Is it every patient that walks in, or is there specific cues that say, this is a person who's going to need we're going to have to get some anti-inflammatory support and some support. We'll get back to what things really do have a positive impact there, but at what point do we intervene?
Well, in my practice, the majority of my patients have seen 6 to 7 specialists. So I'm usually intervening as right during that consult. But, in a primary practice where you're seeing people with basic symptoms and you're not really seeing really complicated patients, you're not really looking at the hypothalamus or actually improving the inflammatory response in any way until something's broken. Isn't that typical that we wait till something's broken to patients complaining enough? So my focus is, these patients are already coming in with multiple medications, multiple supplements. They've tried all kinds of diets, exercises, body work, whatever, and they're still not finding an answer. Then I look at, certain blood parameters to see if the hypothalamus is actually communicating properly with the pituitary gland and lower endocrine glands to get indication of if there is hypothalamic dysfunction that needs to be focused on. And then I measure some inflammatory markers as well to see how much inflammation is actually handcuffing the hypothalamus in terms of its ability to maintain homeostasis.
So I'm glad that's where you went, because that's what I was going to ask next. So if we are going to look for clues that the hypothalamus, let's talk inflammation first. So if we're going to talk about there's inflammation, we're thinking there's inflammation that may be impacting it. What are some general inflammatory tests that somebody might want to talk to their physician about to say, hey, do I have an inflammatory process going on? Because as well as I do, most people go to the doctor and they say, I'm healthy, but there's not one inflammatory test that's run. So you can't manage what you don't measure. So what are some of the inflammatory tests you like to look at to get an indication that there's an inflammatory mechanism going on?
Well, my primary inflammatory test is C-reactive protein, cardioreactive protein, as the primary marker of cardiovascular versus systemic inflammation. And then from there, then I might measure some other markers, some, SED rate, maybe look for anti-nuclear antibody for autoimmunity. I might start looking at some interleukins, but it's really specific to that patient's symptoms before I'm going to, go down that whole inflammatory cascade. I include CRP and in my endocrine panels because I'm looking for inflammation as well as, endocrine functioning to see if the hypothalamus is at the root of the issue. So I assume some inflammation is adaptive, and then how much is chronic is a whole nother issue.
Do you look at markers, some of the other markers, like do you look at uric acid, fibrinogen, homocysteine, elevated ferritin, anemia of inflammation as markers? So for the patient, there's lots of different things we can take a look at. Some people, they can have chronic inflammatory issues going on, and CRP is normal. but there may be some of these other ones that are good, that are going on. So those are some of the tests. Then you said maybe looking for a pattern of problems with the HPT axis. What patterns might you look for to indicate that there's a challenge with that HPTA axis? Like what patterns would you look for maybe in labs to see that there might be a problem?
So I always look at a TSH with a free T4 and free T3 at the same time. Sometimes I'll throw in a reverse T3. And what we're looking for is, your audience probably knows that TSH should be on the opposite side of free T4 and free T3 levels. And so oftentimes you'll have a patient who has hypothalamic or hypothyroid symptoms, and their T4 and T3 levels look to be within normal limits, and TSH is in normal limits, but they're not on a seesaw. So the TSH may be in the low end of normal, and the T4 and T3 also in the low end of normal, and that's not appropriate responding. We should literally see it balancing. So if I see T3 and T4 at the very low end of normal and TSH up at the upper ends of normal, that's a normal response. So we're looking at really that hypothalamic cue, that is it responding appropriately to the T4 and T3 levels? And then at the same time, I also look at the adrenals by looking at just starting with like a DHEA sulfate, just to see what how much adrenal function there is to begin with. I don't do the cortisol right away. I also check prolactin levels. I do them at 8 a.m. in the morning. Dyscircadian prolactinemia can cause all kinds of issues with receptor site responsiveness to both thyroid hormones and steroid hormones. So I'm looking at prolactin as well. And, according to, their gender and their age, I may throw in some FSHs and LHs and, looking at some of the gonadal axes as well. But trying to put it all together and looking at it all at the same time is important to really see, is the hypothalamus doing its job the way we expect it to? And oftentimes it's just missed. I mean, most of the providers, when I get blood work in from patients, they do very little work at the same moment of time to really look at those functions, or they just don't get a full enough panel to really see those axes.
Well, I think that's the error that everybody grew up and taught in, and the goal is really we have drugs that treat a diagnosis or a disease, and that's really where the attention's put. It's not typically look at the higher level. Typically, when somebody's taking a look at that level, they're thinking, I got a tumor, a mass. They're not thinking along the lines, I don't think, of just dysfunction. So let's talk about the thyroid panel. Since this is a Thyroid Answers podcast, let's talk about that. Maybe get into a little bit into the mechanism of what they might see. You said a lower TSH and maybe lower T4 and T3. How do you see, what's the mechanism that you'd see driving that?
So that's usually, so when we see central hypothyroidism, we see a thyroid, the thyroid hormones don't match what we would normally see with the TSH, which probably means that the thyroid releasing hormone is not being released appropriately, which most likely means, and again, we don't know for sure because we can't test this, that there's some bit of resistance at the hypothalamic level to T3 and T4. So it's not reading it appropriately. And so that can be an issue as well. Knowing that, thyroid releasing hormone also instigates prolactin production, looking at the prolactin at the same time helps to read those levels to see if there's any thyroid hormone release at all, and is it appropriate.
I might give a different mechanism there, though. That may be appropriate, but the inflammatory cascade is going to increase the conversion of T4 to T3 at the PVN. And when that happens, we're going to get an upregulation of the sympathetic nervous system, and we're going to get a reduced production of TRH. So I don't think it's necessarily like an inappropriate or a lack of response. I think the hypothalamus is getting saturated with T3 with that inflammatory mechanism. The PVN doesn't have deiodinase 3, I don't believe, to do the deactivation. So you're only getting, with that inflammatory response, you're getting the T4 to T3 conversion. That's saturating the PVN, and that's going to create the upregulation of the sympathetic nervous system and the decreased production of TRH. And so for the listener, if the TRH goes down, TRH is going to then not be driving as much pituitary function and what we call TSH. And so TSH goes down. So brain saturated, therefore the pituitary gland is going to be downregulated a bit. Now the pituitary it still has going to be taking input from the circulating T4 and T3. So we're still going to get some TSH, but I think that's why it gets tamped down a bit. And that's where we see that pattern. So I agree with you, but I think there's that other mechanism potentially as well. And then for the listeners,
there's definitely that other mechanism, but again, it's not something that we can look at. So we have to kind of guesstimate at what might be going on and then try to, give some kind of support therapeutically and see if we can't change those numbers around so the patient's feeling better, not just treating the labs, but the patient's symptoms to make sure that they're actually have a metabolism that is healthy and appropriate for them.
Yeah. So in integrative space or functional space, I think sometimes what we see is we might see somebody with a T4 and T3 that's still maybe towards the lower end of the lab reference range, but maybe outside of somebody's predetermined optimal range. TSH may be not appropriately elevated, but still outside of somebody's optimal range. And somebody might say, well, the solution here is just to give them T4, T3 separately or give them armor. What's your thought on that?
It's not where I start. I always start with supporting their hypothalamus first, nutraceutically, and then look at, besides the free T4 and free T3, look, make sure we're not seeing any, auto antibodies, TPO, thyroglobulin antibody, but also look at reverse T3. Are we getting too high of a conversion at the liver level of reverse T3? Is that what's going on? But mainly I start with hypothalamic support because usually just supporting their hypothalamus rate basically changes that mechanism so that the hypothalamus becomes more sensitized, that high T3 saturation lowers, and there's more of an appropriate response between the hypothalamic, pituitary, and thyroid axis. And it does take time. It takes at least 90 days to actually fix that axis. You're not going to see it immediately, but they'll feel better faster. Their thyroid receptor sites get upregulated. They're just going to feel better, but you're not going to see it in the blood work right away.
Well, I think if you're addressing the inflammatory process at the hypothalamus, it's going to have a better impact. I don't think giving more T4 and T3 in that situation is going to be overly beneficial because if the hypothalamus is already upregulated due to the inflammatory mechanism and the receptors are about 10 times more sensitive at the pituitary and the hypothalamus than in most of the peripheral tissues, you're going to quickly saturate the hypothalamus, drive it even further, and then create a greater loss of thyroid function. So I think that happens too much in our space where people try and treat this range that's outside of an optimal range instead of sitting back and maybe doing what you're doing and saying, wait a second, what's this pattern that we see? And I think it's really important. And I think some of the things you said is looking for the pattern in things potentially other than a thyroid panel when somebody's got hypothyroid symptoms, because if you only look at the thyroid panel in isolation and you're not looking at inflammatory markers, you're not looking at other tissue markers to say what else is going on and what's the big picture, then you get micro-focused on treating or trying to manipulate a blood value instead of actually getting potentially the root issues. Right.
Exactly.
So
really focusing on the root rather than just looking at treating blood and helping the patient's body, if they still have a functioning thyroid gland, make its own hormones. And I've seen that. I've seen patients on thyroid hormone be able to get off it once we improve that axis. It just takes time.
Oh, I see it every day.
Yeah.
I mean, I would tell you, and I think the literature is starting to show this, that there's approximately 90% of the people on thyroid medication are on it inappropriately.
Yes, I would agree.
And the starting on thyroid medication when you don't need it is like starting on crack, because you get that taste, that hit of a little bit more thyroid hormone, and you have the little honeymoon, and then it goes away because the body says, whoa, we didn't want this hormone to begin with. Let's slow it down. There may even be an upregulation of the thyroiditis as a result of what's going on. And the person they get their hit, and then they plateau, and somebody says, well, if that was good, let me give you a little bit more, give you a little bit more, give you a little bit more. And then the T4 is not working anymore. T3 is getting worse as the dose gets greater. And then they wind up on the T3 train, and that's another nightmare. And all of those things potentially create more stress and strain at the hypothalamus, I would argue, because you're constantly upregulating it, and you're constantly upregulating the sympathetic nervous system, which is going to downregulate the parasympathetics, but keep that inflammatory mechanism going.
Oh, absolutely. I mean, overdosing with any hormone is just like screaming at the hypothalamus constantly. It's not going to be able to regulate the rest of the endocrine system when there's one system that has kind of taken over, and it's not following a circadian rhythm. It's not following a seasonal rhythm. You know, our thyroids don't produce the same amount of hormones season by season. It's constantly fluctuating.
They do not. You're correct.
Yeah. And we can't, as providers, just give that perfect dose for them that's going to stay with them forever. You have to fluctuate that. And we don't do that. We turn that whole mechanism off by overdosing them.
Yeah. For the listeners, the values are, as you said, skew seasonally. So depending on when you're looking at those values, they can ebb and flow, and especially like TSH can push outside that lab reference range even, and it's not technically a problem. That TSH is upregulating the drive, potentially more T4, or maybe even T3. When there's reduced peripheral conversion, somehow, I don't know the exact mechanism, but somehow that pituitary gland with the same signal of TSH going to the thyroid gland changes the ratio of T4 to T3. I don't think we know how that occurs yet, but it's the same signal. But I think it's like yelling, yo, like if I say it that way, that means one thing. And if I go, oh, that means something totally different. But somehow that pituitary signal can change based on, do I need more T4 or do I need more T3? So it's amazing. The other thing is, as we get older, it's thought that we probably need to sustain a little bit higher TSH as we get older. That's been discussed in the literature as well. So it is, I think it's really important that we're not overloading the systems and looking at too narrow, too tight, and too precise a range that the lab values need to stay in. Lab values need to be interpreted, not read. So we need to look at a value and say, is that appropriate for my patient or not appropriate for my patient, given everything else that's going on? Let's talk about, you talk about in integrative medicine and functional medicine, we talk about root cause issues. So let's talk about what are the root cause issues when it comes to hypothalamic challenges. I mean, we could talk about inflammation, but what's driving the inflammation, I guess, ultimately, but what do you see as driving what are some of the primary causes of this hypothalamic dysregulation or dysfunction?
The primary cause in the research shows that it's either malnutrition or overnutrition. We know that diets that are high in saturated fatty acids and trans fatty acids, those diets that are high in sugars, actually will drive the hypothalamus into a microinflammatory state and cause dysfunction. We also know that certain toxins, certain heavy metals, viruses, we know Epstein-Barr virus affects the hypothalamus, cytomegalovirus affects the hypothalamus, SARS-CoV-19 affects the hypothalamus. We know that toxins like cadmium can affect the hypothalamus, mercury, arsenic. So there's quite a bit of toxins in our environment that can also affect the hypothalamus. And then you've got your endocrine, disruptors as well that will affect the hypothalamic feedback mechanism. So it's not protected by the blood-brain barrier. So it gets to read everything that, you're dealing with. One of the big factors of hypothalamic dysregulation is loss of sleep. People who work graveyard shifts, people who just aren't getting enough sleep can dysregulate hypothalamic function, which you'll start to see in endocrine functioning as well. So
somebody might listen to that and go, okay, so everything causes problems with my hypothalamus, right? So where does somebody start when they, in your model of care, where do they start? If it's almost everything, right, in their environment, right?
Yes.
So where do you start, and why is the hypothalamus becoming so dysfunctional? Is it just Is it the thing? I always talk about the load on the system over a
Mhm.
sustained period of time is really the bigger issue versus the individual insults. But how do you see it?
Well, it is a load on the system. The one thing isn't going to occur, but we do see. So, for instance, with a 3-day binge of high fats or high sugar, you'll see microinflammation in the hypothalamus. It doesn't take long. It can even happen after one meal. So, how long is that? How chronic is that? How chronic is that malnutrition or overnutrition? We know, for instance, when your body fat's really low in women with hypothalamic amenorrhea, it's usually super low body fat and undernutrition. So it is very responsive to what you're eating, what you're taking in, but it does take time to become dysfunctional. It wouldn't make sense for this master organ to, fall apart at a whim. So you're going to see dysfunction in other places. It's not going to spend its energy on keeping you happy and helping you to be fertile when it's trying to keep your heart beating and your autonomic nervous system running. So it's not going to fall apart right away. It's going to take chronic insult that's going to cause it. Although traumatic brain injury, I see a lot of that. People who've had head injuries will have hypothalamic dysfunction. Any children who've had chemotherapy, they have like almost an 80% chance of developing metabolic disorder, and it's due to hypothalamic dysfunction. So anybody who's had a stroke, a brain tumor, anything that's going on in the brain can actually affect the hypothalamus as well. So it's affected more than we realize, and it's not paid attention to a lot until somebody gets really sick. And even then, I just consulted with a young woman who, just in reading her narrative, she wasn't a patient. She kind of came in as a coaching consult, and she had, type 2 diabetes and, all kinds of polycystic ovary syndrome and on major medications, and nothing's under control. And the blood work she sends in, nobody's looking at any inflammatory markers on her. Nobody's looking at anything. She's seeing multiple providers. When I went back in her history, she had a brain tumor when she was a toddler and had chemotherapy. And I asked her, when's the first time an endocrinologist started following you? She was 7. She's had hypothalamic dysfunction. Hadn't seen her. She's on Zoom. I'm like, how tall are you? What's your size? Super small. When did you start taking growth hormone? She had hypothalamic dysfunction from the beginning because of the surgery and the chemotherapy. And nobody recognized it. She just saw multiple different providers to treat this part, that part. If we don't, deal with the core issue, she's not going to live into middle ages.
Yeah. So I want to go back. You said something about high fat diets. So we live in this time where we've got a lot of people doing ketogenic diets. So I want to kind of clarify this. Is this all fat-based diets are problematic, or when you say a high-fat diet, are you referring to more of these kind of oxidized fats in our processed foods?
Yeah, so trans fats and high saturated fats. I mean, saturated fats that are more than 30% of the total fat content are going to be high for the hypothalamus. So the hypothalamus needs fat. It definitely needs it. I'm not promoting a low-fat diet at all. It just really is responsive to polyunsaturated fats, especially omega-3 fats. Does really well with high polyphenol olive oil and, the monounsaturated. It doesn't do as well on super saturated fats and trans fats mixed, especially with a high glycemic diet. So that combination is kind of lethal to the hypothalamus.
Well, I would definitely agree. If you're doing
everything, but
yeah, high fat, high carb is bad, right? It's lots of fuel, and that typically means low protein. And you better have super high activity and metabolism to deal with lots of fuel. That otherwise it's going to be problematic. But does the literature show that people on ketogenic diets have more hypothalamic challenges?
I haven't seen any studies that have shown that, but the majority of the ketogenic diets are usually pretty, that I've seen and my patients are following, are pretty balanced in getting enough poly and monounsaturated fats along with those saturated fats. They're not all sats.
Yeah. Okay. So
and they're also promoting eating produce and vegetation, so because they're not getting in the high starchy carbs, they're eating enough vegetable rich antioxidants and polyphenols to actually decrease the inflammation that their extra fat might be causing the hypothalamus. So it's not a sad diet. It's not.
Yeah, I think we to some degree we've created a problem, right? I think we create diet confusion for people because they're like, oh, is it like keto or vegetarian or vegan or carn? Like which diet's better? And then they get confused and they just eat what's convenient. Versus, I think the benefits of all of these whole food based diets is they're all probably healthy for the most part. If we're eating whole foods primarily, we're going to probably be in pretty good shape because you typically tend not to overeat a lot of whole foods. It's typically the ultra refined processed foods that are more oxidized, more damaged, more frankenfood that we're putting into our system that's problematic. And I would guess the research would kind of prove that out. But I do think when we see people say, this study says high fat diet is bad for you, they're not really being honest as to what that is sometimes. And it's not like a healthy whole food based higher fat diet. It's usually the
No,
more
it's
processed
we always
junk.
start when we look at studies, we're always starting with mice and rats, right? So they're
Yeah.
basically overfeeding these little mice, super high fats and then, measuring hypothalamic inflammation or super high sugar. They're not giving them a variety of foods. They're not balancing it out. The poor mouse doesn't have a choice between its mouse chow and this high fat. All they're getting is the high fat or the high sugar. So it really is about whole foods. I mean, I promote, yes, my name is Greek. I'm Italian, but I promote a Mediterranean diet. It's, it's fairly well balanced. You get enough fat in it, enough protein, and you're getting lots of different produce and it's colorful. So, it's pretty easy to follow and the parameters, across the line with obesity, diabetes, cardiovascular disease, it always rates in the, number one in the majority of these throughout the years. So I think it's the easiest to follow. It's just that, most Americans think Mediterranean diet and they're eating pasta all the time, which is not the Mediterranean diet.
Yeah. And I say it on this show all the time that, um, don't worry about the food religions, just focus on a whole food based diet.
Exactly.
80-90% of the time, and you're probably going to be in a great shape. And if you go to a ketogenic diet for a period of time and you feel better, that's great. You're probably changing your gut biome a little bit. If you go vegetarian for a short period of time, you might feel a little bit different because you're changing some things. But in general, a well-balanced whole food-based diet, to me, is the place to be. A Mediterranean diet fits right into that.
Yeah, it's the core diet. And the thing is that most of us haven't been trained to listen to our bodies. We go by our heads. I mean, how long has medicine told us that we shouldn't be eating any fats at all? And we realized we should be eating fats, or, we had the, fake sugars. I grew up in the generation of non-fat and fake sugars. And actually that's how I got started in the hormone world. Is I had a hypothalamic amenorrhea because I was an athlete and way underweight. And then I ended up giving birth to a child who had all kinds of endocrine issues. And I had to learn, hormones right out of nursing school. And so went back and got my grad degree to try to, help this child navigate through the medical system. So, and I know a lot of that had to do with the fact that, I just wasn't healthy enough to give birth. I didn't have enough body fat.
Well, yeah. So this is a personal question. You don't have to answer it if you don't want, but
Go ahead.
Was in that state, because I say this to women a lot of times who have thyroid issues and hormone dysregulation. They're like, hey, I want to get pregnant. I'm like, well, and they've had miscarriages or they haven't been able to get pregnant. I'm like, your ability to not get pregnant is because there's other things going on. Your body is not putting function towards hormone regulation. But you see this with people, especially female athletes who are overtraining, under eating, that hormones become dysregulated. Did you find it easy to get pregnant, or was it difficult to get pregnant? And there's the outcome, because sometimes we see in today's world, people have an inability or struggle to get pregnant, so they just think, hey, I'll just force more hormones into a system and force a pregnancy. But in my thought process when they're going through that, and what I try to convey is, yeah, it's great to get pregnant, but you still need all that hormone signaling to work appropriately through the pregnancy to have a healthy child. I think the fact that we've got so many people on thyroid medication probably contributes to some of the neurodevelopmental challenges we're seeing. And I think the literature it shows that that's the case.
I definitely agree. I did infertility work for years in a gyne practice, and I would tell the patients the reason you're not getting pregnant is because you're not healthy. This is
Right.
before I was even focusing on the hypothalamus. So let's get you healthy first and then get you pregnant. Because if you do happen to get pregnant because you're throwing out an egg and you end up getting pregnant, the likelihood is you're going to develop preeclampsia, hypertension in pregnancy, gestational diabetes, and you're going to have postpartum depression. You're going to have issues, or you have a premature baby. And that's what happened with me. I was able to get pregnant. I did not have trouble getting pregnant, even though I had amenorrhea. I was, okay, there's where the intuitive part is. I'm an intuitive integrative nurse practitioner. I dreamt I was going to get pregnant, told my husband, this is the month we're going to have a baby. He's like, what? You don't even have periods. And I got pregnant. But I had preeclampsia so severe that it was toxemia and had it postpartum. Baby had intrauterine growth retardation, weighed 2.5 pounds when it should have weighed 4.5 pounds at 31 weeks, was born prematurely and had all kinds of endocrine issues and ended up with ADHD, which is, I am sure, was because I was so undernourished, before and during the pregnancy. So I gained all of 12 pounds in the pregnancy. That's not a healthy pregnancy. So my focus has been get my patients healthy, because that is not the way to do it.
Yeah. And it sounds to some degree mean, like I know you're in a rush to do it, but you don't, that's not what we should be doing first. We should be trying to get you healthy first because of the potential downside through the pregnancy and then the potential challenges for the children. I mean, we've got an explosion of children being born with neurodevelopmental issues. And I would argue that the inflammatory processes affecting the hypothalamus, thyroid signaling, and all this hormonal signaling is at the root a lot of this stuff. We're looking, and everybody's looking for the magic thing that's causing it. I don't think it's a magic thing. I think it goes back to the same thing we're talking about. It's the load, the impact it has on the immune inflammatory process, the hypothalamus, the pituitary, the adrenal axis, all of these pieces. When we have this chronic stress inflammatory mechanism going on, it's not just a thing that's going to affect the male and the female. We should be fair in that situation, right? Because it affects the male sperm and development and everything else.
Yeah.
But man, it makes it, I don't think we should be surprised, given the challenges that we have today with chronic low-grade inflammatory processes and the impact it has on our physiology, that we're having more kids being born with neurodevelopmental challenges.
Yeah, no, we shouldn't be surprised. But then the cool thing that I have found is that once I started, focusing on the hypothalamus, I developed a nutraceutical that kind of supported it. I have not had to deal with infertility in my patients at all. Like they pretty much, they're like, I want to start this work. I'm like, let's feed your hypothalamus for 3 to 6 months and see where we go from there. And the majority of them will get healthy and get pregnant and have a healthy pregnancy. And I have them where before we even had the nutraceutical, and have unhealthy pregnancies, gestational diabetes and hypertension, and children with learning issues, and then get on the nutraceutical, get pregnant with that, and boom, everything's fine. So I know that your hypothalamus can get corrected with the right nutrients. And of course, it's lifestyle. They can't stay up all night. They can't be eating a standard American diet. They can't be so stressed or respond to stress in such a way that they're always in fight or flight mode. They have to have a healthy mindset. If they don't believe that they can, get healthy, they're going to kind of sabotage themselves. But so it really is 5 pillars. But I have seen a big difference in people, that had real issues with fertility, be able to get pregnant and be able to have, healthy children. I've used it with children that do have neurodevelopmental issues, and it's really helped to wake up those brains, feed those brains, and get that hypothalamus functioning better. So I do think that you can fix it. It just requires some attention, and it requires changes in lifestyle.
Yeah. Well, people can listen to this and they'll be like, oh my gosh, there's one thing I can take and it fixes everything. I would say we'll get to your individual product here in a bit, but you could take things that are going to have an anti-inflammatory effect, but if you don't address and I talk about what we call the fitness factors: your dietary fitness, your emotional fitness, your chemical fitness, your metabolic fitness, your sleep fitness, your respiratory fitness, your emotional fitness, your habitual fitness. Like, if you don't address those keys, and those are the foundational things you're talking about, you're just taking the anti-inflammatory is not going to fix it. You have to address all these other factors. Which brings me to the next question I want to ask you, which is, how do you see, or can you explain the role, because we talk about the brain 1, brain 2. So where do you see the role of the GI tract in this whole hypothalamic inflammatory cascade?
Well, I know that, we like to think of the brain in our head as brain 1, but I don't see it as brain 1. I actually see your heart as brain 1, your gut as brain 2, and your brain as brain 3 when it comes to survival. And brain 2 is super, super communicative with the hypothalamus. The hypothalamus has direct communication. It has autonomic nervous system communication and hormonal communication with the gut and the gut microbiome. So it communicates with the neuroendocrine system in the gut and also communicates with the gut microbiome. So that's where it's getting all its nutrients. That's where it's getting its first inflammatory, signals. That's how, hormones are metabolized and then, released, detoxified. It's super important that our gut's healthy. And if it's not, then that what we call the gut-brain axis is really the gut hypothalamus axis.
So today, I don't know if you have any literature on this or have read any, but there's this new style drug that's out, the GLP-1 agonist drugs. Have you heard of these things?
Yes. I've done some research on them.
So these are like the hot thing. Everybody wants it, right? Because it's the easy way to lose weight potentially. We're not getting into all the negative side effects as well, but how do you see, what impact have you seen from people taking these medications on hypothalamic function or physiology?
Well, to be honest with you, the majority of my patients want to do things naturally, so I don't have anybody on those drugs. But theoretically, what I would see is you're just hitting one button in the hypothalamus. You're not hitting them all. There's multiple buttons in the hypothalamus that control hunger, satiety, and metabolism. And GLP-1 receptor site agonists are just hitting one of those buttons. So we have a lot more work to do. But I think when you're always pushing one button on the control panel, you're messing up the mastermind under the control. So I think that it has a limited use. I think, it's helping people that, lose weight, but it's not the only thing. And I think we're going to see issues in the long run in terms of the hypothalamic sensitivity to other factors like leptin sensitivity, adiponectin sensitivity. We're going to see other issues when you're just constantly, agonizing that one receptor site. So,
yeah.
I think it's too focused. I think super focused therapy takes away the body's ability to multitask the way it's supposed to, according to what the environment and the input is.
Yeah, I think it's problematic. It's going to be, I think it's problematic. I think people are seeing some benefits from it, but we're also seeing a lot of negatives from people as a result of taking it. And
they haven't seen the long-term effects from it yet. I mean, it's brand new. So what's going to happen down, long-term wise? I mean, are these people going to have to be on this for life because they're never going to turn on their natural systems?
Yeah, I think that's what they're saying. Right. And if you think about it, if these people have GLP-1 challenges, more likely they have gut dysbiosis going on.
Oh, absolutely.
Right.
Absolutely.
So why don't we just address the gut dysbiosis? But
it's where we have to start.
Right.
As much as I focus on the hypothalamus, it's the gut that I start with first. The majority of things that I'm going to do for my patient is going to go through their mouth and they're going to have to swallow it. And if their gut's out of balance, we're not going to be able to get the, bioavailability that I'm expecting. So.
Right. I mean, if you have a chronic GI issue and you're taking lots of supplementation, you're probably wasting a ton of money.
Yeah.
So there's lots of things on the market to try and reduce inflammatory signals, but what is the literature shown to be the most effective things to get to brain, to get the hypothalamus and help calm the inflammatory cascade? I'm a big fan of sulforaphane because I know it's high absorbability. I think the literature says within 15 minutes, it's getting to brain. So what have you seen in the literature as nutrients that have a really powerful effect on the hypothalamus and the other inflammation, especially at the hypothalamus?
Well, for the hypothalamus, in terms of inflammation, polyunsaturated fats, omega-3 rich, are very effective for the hypothalamus. There's a lot of research looking at amino acid penetration to the hypothalamus, particularly branch chain amino acids that affect hypothalamic functioning. And the hypothalamus is also super sensitive to most of the phytochemicals that are, within different botanicals, et cetera. The phosphatidylserines, phosphatidylcholines, break through that blood-brain barrier and can actually help to increase the receptivity of the hypothalamus to the lower hormones. So there's quite a few different nutrients that I'll use. I usually offer kind of a potpourri of nutrition to the patient's hypothalamus, knowing that they probably have multiple areas that I'm not even seeing that need some help. So, and we also know that things like, curcumin makes a huge difference in inflammation at the hypothalamic and brain level as well. So there's different nutrients that are pretty simple that affect the hypothalamus. And it's just a matter of them getting in what they need and in a bioavailability. Are they going to actually be able to, take it in and, get it there? Like CDP choline is one of my favorites for the traumatic brain injuries and the injuries I see to the hypothalamus, post chemo or after stroke. And it's got great, oral bioavailability. It's equivalent to intravenous, and it works well. So
from, I think you talked about this a little bit before about, I think we talked about a little bit about genes and how the hypothalamus can have an impact on genes, genetics, epigenetics, and DNA. So I don't know if we finished that conversation. What's the
some of my questions? So basically, the idea behind that is because the hypothalamus is orchestrating the neurological system, the immune system, the endocrine system, and we know that particularly steroid hormones actually affect the nuclear membrane receptors and affect DNA, that when the hypothalamus is dysfunctional and not doing its job properly at orchestrating adrenal, sex steroids, then you're going to see some changes in genetic expression. So what I have seen is patients who have had, different types of genetic aberrations that are causing health issues no longer show the expression of that. Like, for instance, with methyl tetrahydrofolate reductase genetic issues, if they have high homocysteine levels, then we know that they're basically not using that particular B vitamin appropriately. They're not converting it appropriately. I see once I start balancing their hypothalamus out, that we see a reduction in that homocysteine without even giving them methyl tetrahydrofolate. So my question is to genetic scientists, which I don't have that ability to do this in clinical practice, but we've identified millions of genes, but what's actually being expressed is what we're seeing in that patient. How much could they be borrowing from that could be expressed that could counterbalance these maladaptive genetics? I think that's what's happening. And I think that's what we're seeing in epigenetics is a shift in expression of DNA, even though we're identifying certain disease causing. Are they really disease causing, or are they just maladaptation to that environmental issue? And if the hypothalamus was functioning at the higher level, would we not be able to turn on expressive genes that were actually more adaptive to the situation the person is in?
Yeah. For the listener, we're kind of talking about genes and genetics and what the genes do, but what we're really focusing on here is talking about epigenetics, how the environment and the signaling in the body causes genes to express themselves. And people talk about polymorphisms like MTHFR polymorphisms and think that, I have a polymorphism, a heterozygous alteration, or I've got a homozygous polymorphism, and therefore I have a defect and this thing will never work. Well, I don't know. When did you start having problems? When I was 35. How long do you think you've had that gene? I don't know. Well, you've had it since you were born. So if that was the only problem, you should have had problems from the start, not necessarily when you're 35. But And for every gene polymorphism, there's probably polymorphism somewhere else that can help regulate for every down regulation.
Absolutely.
Or just like we talked about homeostasis versus allostasis, hey, when the body, because of what's going on signaling wise, says, wow, I need to upregulate that MTHFR gene, or I need to downregulate that based on the signaling. So I'm more with you along the lines that a lot of people get their genetics done and then try and treat their gene polymorphisms. I think it's a terrible idea. You get these reports from some of these places and they'll say, hey, you have this polymorphism, you need B6. And a couple pages down, they'll say you have this polymorphism, you can't take B6. And it's like, what? Where are you getting this stuff from? Or because of these genes, you're going to be overweight. Well, I don't know that that's the case. I think it's more lifestyle factors and everything else that's the case. But I get it. People they're trying to make money, and so they're doing these things. But I think the genetics can help us tell a story of where we might see potential challenges if there's inflammatory mechanisms or deficiencies. But I think we ought too often go to adding more supplementation when we see a genetic polymorphism versus saying, what's causing that, what might be slowing that gene down naturally. I think my friend, Dr. Ben Lynch, wrote a book called Dirty Genes, where he talks about soaking and scrubbing. And essentially what Ben's talking about there is, before you go to adding stuff, let's get rid of the stuff that would alter or reduce the function of this thing inappropriately and address those things. So, hey, inflammation negatively impacts a lot of these things. Why don't we identify what's triggering chronic inflammation and address the inflammatory process? And then maybe that gene works more appropriately on its own, even though you've got a homozygous polymorphism.
And we haven't identified all the millions and millions of SNPs out there, all the different genes. So I just don't think we have the ability to really say, looking in our crystal ball and, okay, this is it for you, because you have this DNA. Your DNA is not set in stone. It's kind of like playing cards. You get dealt a certain hand, but you also have a whole stack of cards here that you get to borrow from. So I may have been dealt a poor hand, but it's how I play this hand is whether or not I'm going to win this game. And sometimes I can throw out that deuce and grab an ace and win the hand. And I think that's what's happening. That's a very basic analogy, but to help people understand, that's what's happening in your DNA. The lifestyle choices you make is how you're playing your genetic hand.
Yeah. So I think the lesson to the listener is, don't buy in too early into, I need to get my genetics done and then treat those. I think the primary focus should be on, how am I living my life? That's going to have the biggest impact on how your genes regulate, and not necessarily the micronutrients that you may learn on a genetic report that you might need to take. Because if you have a poor diet, poor lifestyle, poor habits, poor behavior, emotional basket case, there's not enough supplements in the world to fix that.
Right.
You have to address those things. So I know you said you developed a product that you've seen helping your clients. Tell us a little bit about the product.
So the product is called Genesis Gold, and it basically has those phytonutrients, those amino acids, and the PUFAs in it through mostly sea vegetation that actually helps to feed the hypothalamus. It's in a powder form. Patient drinks it. If they have food sensitivities, allergies, etc., I have the amino acids bagged separately to start those people off before they get onto the full formula. And what I've basically found is that it's replaced the majority of the supplementation that I've had to give my patients to try to get them into balance. And, it's helped with the infertility issues. It's helped with, the climacteric issues. It's helped with inflammation. The only side effects I see from it is if their gut is in balance, they have SIBO or Candida overgrowth, they'll get gassier with it because the nutrients in there are going to feed those guys too. And so we just basically got to get that gut back into balance before we start feeding it this, highly bioavailable phytonutrients. So it's I think one of the most dramatic cases that I've had was a woman who came to me with panhypopituitarism, basically means, for your audience, that she wasn't producing any of her own hormones. She never went into menarche, didn't start periods. She was in her early 30s when she came to see me. She was on thyroid replacement. She was on cortisone because she didn't produce enough cortisol. She was had insulin resistance. She had anxiety and depression, was using sleep aids for insomnia. She had to exercise like crazy to keep her weight under control and had to be on a severe diet. So when she came to me, she wanted to switch from all her synthetic pharmaceuticals to natural. And so I did the best I could. I still felt I wasn't getting to the issue. About 3 years into our relationship, I finally had the Genesis Gold created. And I asked her, let's just see what happens if we feed your hypothalamus. And within 18 months, we were able to get her off everything, all of her hormones. She no longer had to take any bioidenticals. She had periods for the first time, no thyroid treatments, no dream, nothing. And so because she had periods for the first time, at this point, she's like close to 40. And I said to her, you need to consider, if you don't want to have children, you need to consider using a barrier contraceptive. And she laughed at me because she said, I've been told all my life I'm infertile. I'm like, well, you're not now. So she ended up having a healthy baby boy at the age of 42.
Ooh, good for her.
So, but what I'm saying is, if we can wake up the hypothalamus through nutrition, through lifestyle changes, and take away a lot of the chemicals that are probably interfering with its functioning, I think your body can heal.
So you said it was marine based. In today's world, I know I get this from a lot of clients. They're worried about using marine based products because of the toxicity of the water. How do you address that component?
So every ingredient, each of the individual ingredients are tested for heavy metals, et cetera. And then the whole product itself is tested. But I've had this formula since 2000, finally got it manufactured in 2003. I have changed where we harvest the species of the different vegetation, and whether or not we do a wild harvesting or we do farmed species according to the potential toxicity load, according to what's happening in the world. So, after Fukushima, we no longer harvested in the North Pacific and went to the Atlantic for those particular kelp that we were looking for. So the formula has changed over the years according to what's happening on Mother Earth. And it's just, sea vegetation is highly rich in nutrients, especially minerals and antioxidants and PUFAs. So it's just it's a rich food, and it's where our, the majority of our ancestors began, is somewhere near water, the sea.
All right, so let's kind of wind down this conversation with the way I usually like to kind of finish up a conversation, which is, what are some of the key steps that a person could walk away from this podcast and say, all right, I'm going to do these things to start trying to improve my health, improve my chronic health issues, and potentially their inflamed hypothalamus and stressed out hypothalamus? What are the key things that you recommendations that you'd give them?
So number one is they need to get enough sleep. They need to sleep in the dark, and they need to turn off those screens that are emitting blue lights after dusk. Hypothalamus is super sensitive to light, and the day-night signals, your nocturnal hormones, are way different than your daytime hormones. And if the hypothalamus isn't signaled properly, you won't go into nocturnal mode, which is when your immune system is cleaning house and getting rid of a lot of that inflammation. So if you can turn off your devices after dusk and go to bed at a decent time and try to get 7 to 9 hours of sleep according to your age in the dark, you're going to do a world of good for your hypothalamus and its ability to orchestrate your immune system and deal with chronic inflammation. That would be number one. It sounds easy, but it's a lot harder because we're addicted to our devices. I am so light sensitive that like everything in my room that could potentially emit a light gets covered up. I don't have anything in the room, but like when we go to hotels, I cover everything up because your body is light sensitive. We just get used to like kind of a low level of REM sleep instead of going deep into REM sleep. Mm-hmm. Getting up early in the morning with that sunlight helps to reset the hypothalamus so it can make enough dopamine and turn off that prolactin. So really following a good, day-night cycle. And being active earlier in the day rather than later in the day actually helps to boost up the neurotransmitters that help the hypothalamus do its job properly, and also signal to the hypothalamus that your metabolism is humming. And then eating that Mediterranean diet or any plant-based diet that you have enough protein for your lean body mass, at least a half a gram per pound of lean body mass, and that you're getting an adequate amount of fat. And then, basically the mindset, really trying to reduce how you react to stress, not always being in that fight or flight mode because you're consuming, negative news and things that are just constantly stressing you out, but learning how to mitigate your stress through mindfulness practices, deep breathing, getting out in nature. Stress is the biggest killer. It's the new smoking. We need to mitigate our stress response, and then feeding your hypothalamus what it needs to do its job properly.
In general, if you're eating a whole food based diet, good digestion, a lot of the things your hypothalamus need are going to be in those healthy foods that you're digesting appropriately. The reason we talked about the gut being one of the key things that we need to address, right?
Hopefully. I mean, I've been on the Mediterranean diet, a healthy diet, since I was a child. I'm Italian American. I married a Greek. We eat really well and cook really well and have, organic foods, grow a lot of our own foods. It's still hard to get everything that we need. So, I had the hypothalamic amenorrhea up until about the age of 39. At that time, I was using bioidentical hormones to give myself a period. Once I started taking my beta product for the Genesis Gold, I had periods within 2 months and had normal periods until I was 56 years old. Went into menopause much later than my siblings did. So I do believe that your hypothalamus needs a little bit more than we can get from our diets alone. You have to be pretty pristine.
So I guess that brings up one last question.
Yes.
There is a huge push, especially in the integrative and functional medicine side, maybe the allopathic side as well, for women to be on bioidentical hormones in the second half of their life, as if, on one end, especially in the functional space, we talk about, you got to, the body, working with the body naturally and kind of not working against the body. And yet doesn't the body naturally reduce the amount of sex hormones a female has in circulation? And is what we're experiencing that the big guy screwed up and women got the raw deal? Or is this a matter of that the reason women don't feel well in the second half of their life is not so much that they have to be on bioidentical hormones to feel well, but maybe because they have hypothalamic issues impacting and inflammatory issues impacting how the hormones they have actually work?
Well, it is true. So in countries that aren't as stressed as, let's say, America is, we all go through, all of the global women go through menopause at the average age of 51 and a half. That's pretty much standard. But they do not show signs of aging as early in those less stressed countries. And that's because the adrenal glands can produce quite a bit of the sex steroids, the conversion of pregnenolone and DHEA, and adrenal progesterone will convert into sex steroids, which will hold them longer. But eventually the adrenal glands aren't producing as much as well either. So there's kind of like a second menopause that happens maybe 15 years or so after the natural menopause, and things kind of slow down, and the aging process starts. So I treat my patients according to what they desire and need. And some of them need a little bit of hormonal support and some of them don't. And it's according to what their issues are. If they have, APO4 genes and they have Alzheimer's in the family, we know that if we give them estrogen, and of course I always give them progesterone with their estrogen, early in the menopausal change, we're going to be able to potentially abort Alzheimer's in that situation. So it's very individual for each patient on, what's going to be best for her and how she feels. And I do believe that, if we look at how long our species should have been living, we live a lot longer than what our gonads are keeping up with. And, and male hormones decline as well, although not as drastically. It's the hypothalamic dysregulation from the lowering of the estrogen progesterone that causes the majority of side effects, the hot flashes, the night sweats, the insomnia, the brain fog. Other than vaginal atrophy, it's hypothalamic dysregulation from that bottoming out of the sex steroids. You see that when you castrate someone with a hysterectomy and oophorectomy, or any kind of a chemical castration. So that's basically what's going on. So do we continue to support them? It's up to that woman.
Yeah, I definitely think it's up to the woman, but I think in general, we have a tendency to be like, hey, we're putting people on these. I think before we're considering everything else that's going on. So if that's what somebody wants to do, by all means, they have the right to do that. But I think we have to oftentimes take a step back and say, what's going on with this person to begin with, that they're lower with their normal lower hormone levels should still allow them to feel functional at this phase of life. Why aren't they working well? And I think too often we just jump to, just like we force hormones into somebody who's not healthy enough to get pregnant, we're forcing hormones into somebody who's not really healthy. Therefore, the body's not putting as much time and attention into sex hormone production, even though it's at a lower level. And instead, it's putting energy and time into cortisol, catecholamines, inflammatory chemicals, instead of regulating that. Does giving somebody more estrogen, progesterone, testosterone, that situation help? I don't know necessarily that they may get a hit where they feel good for a while, but then what's the downside if they putting those hormones in and they can't detoxify them very well because of the down regulation? It becomes a problem.
Older cells don't detoxify. Older livers don't detoxify as well. So it really is a play of what are we dealing with here? What is the patient? What are we treating? Trying to get that patient healthy in all realms, and then they still need some hormonal support. You're going to have better metabolism if you've improved a lot of those cellular mechanisms before you give them the hormonal support. On the other hand, if they're falling apart and they can't function at all, you may need to give them hormonal support just to get them to do the lifestyle changes until we can then wean them down. So again, I don't think anything's black and white with any patient. I don't literally prescribe to any, like, everybody has to be on this. Everybody has to, follow this particular diet or exercise regime. I think everybody is different. And, I have women that want to take hormones into their 80s, good for them. And I have women who haven't touched them the whole time and they're aging just fine. It really is a matter of treating that patient individually and letting him or her make that decision according to what you're seeing as the clinician that would benefit, not just today, but their 10 or 20 years from now, 40 years from now. How are we setting you up for a vital life?
Yeah, I think that I think all that's well said and important. And I think that's why it's important to treat the individual, not your protocol, not like, okay, this is what I do on all my patients. Everybody gets their thyroid levels optimized. Everybody gets their sex hormones optimized. And that's my protocol. That if that's the type of practitioner you want, there's plenty of them out there. But I think where we should be from an integrative and functional standpoint is trying to meet the person where they're at. Obviously, what's their goal? What do they want to achieve? But if they're looking for a true functional approach, our goal needs to be make sure they have the minimal amount of stuff they need to be stable, and then get busy addressing what's creating the problem, or as we talked about earlier, the root issues. So. All right. Well, I think we got it covered. So if people want to learn more about you and your product, where can they go?
They can go to genesisgold.com. That's my website. I have a very active YouTube channel, blog posts, lots of information. There's a freebie there where they can join. It's an email list where they join I call it the Hormone Reboot Training. And it's based on the first book that I wrote, which actually helps to educate them a little bit more about what's going on in their body and how the hypothalamus is connected.
Awesome. All right. Well, I appreciate you coming on the Thyroid Answers podcast. And for the listeners, listen to this one maybe once or twice, because or maybe a third time, because we covered a lot of stuff. Did get a little bit technical, but we do that quite a bit. So hope you got a lot of information. And Deborah, once again, thank you for so much for coming on the podcast.
Thank you.